and I welcome you all on behalf of Emcure Pharmaceuticals Limited to another exciting workshop of the No Thrombosis series. We are glad to have completed 8 such successful workshop series so far under the guidance of Professor U.K. Mishra sir, Dr. K. Ashokan sir, and Dr. Jayant of Emcure Pharmaceuticals Limited. We are very to another exciting workshop, the 9th workshop of this series. And it's my privilege and honor to welcome once again our senior faculty members on this podium. I first again welcome Dr. U.K. Mishra sir, who is our course director for this workshop. Sir is the director and head of Department Neurosciences at Apollo Medics Super Speciality Hospital at Lucknow. Sir founded the Department of Neurology at SDPGI in 1987 and also headed the Department of Neurology at SDPGI Lucknow. Sir is the director, executive registrar, dean, and in charge of research at SDPGI. Sir is trained in clinical neurophysiology at the prestigious college in Italy, Sweden, USA as a WHO fellow. He has made some original contributions in the field of stroke, epilepsy, CNS infections, GBS and neurotoxicology, and has over 462 articles to his credit in reputed national and international journals. I now take pride in welcoming our moderators for the workshop today. Our first moderator is Dr. Jayant Roy sir. Sir is the Director of Stroke Program and a Senior Consultant at Department of Neurology, Institute of Neurosciences, Calcutta. Sir is a recipient of 2005 American Society of Neuroimaging William McKinney Award for writing the best manuscript based on clinical research in neurosonology. He is a certified neurosonologist accredited by American Society of Neuroimaging. He has made scientific presentations in reputed forums across the world, including the prestigious World Stroke Congress, and he is a member of editorial board of Journal of Stroke Medicine, member of Global Executive Committee member, Society of Neurosonology India, and member of Educational Committee of Joint World Stroke Congress of 2016. I now take pleasure in welcoming our second moderator for today's program. Our second moderator is Dr. K. Ashokan sir. Dr. Ashokan sir is a chief neurologist and head of Department of Neurosciences at Sri Ramakrishna Hospital, Coimbatore. Sir is an active member of American Academy of Neurology, life member of prestigious bodies like Indian Academy of Neurology and Neurological Society of India. Sir is the president of Coimbatore Neurological Society and also the president of Tamil Nadu and Pondicherry Association of Neurologists. Sir has presented papers across international and national conferences on stroke and epilepsy, and he holds special interest in stroke therapy. I now take pleasure in welcoming our third moderator for the day. Our third moderator is Dr. Sudhir Kumar sir. Dr. Sudhir Kumar is a consultant neurologist at Apollo Hospitals, Hyderabad. He is on editorial board of Neurology India. He was on editorial board of Neurology India from 2003 to 2007 and on the editorial board of International Journal of Neurology and Neurosurgery. He has received many prestigious awards, including the J.C. David Gold Medal Award, the P. Kutumbia Prize, and Dr. P. Koshi Prize in Medicine. He is a PI, principal investigator for many clinical trials on stroke, Parkinson's disease, multiple sclerosis, epilepsy, and he has over 120 publications in various peer-reviewed journals. I would now like to introduce and welcome our speakers for the day. Our first speaker is Dr. Vikram Bohra. Dr. Bohra is a senior consultant neurologist and chief intervention neurologist at Artery, Jaipur. Sir has done neurointervention observership from the prestigious Mount Sinai Hospital, New York, and he holds special expertise in the treatment of brain hemorrhage, stroke, Parkinson's disease, migraine, epilepsy, seizure, and spinal cord disorders. He'll be presenting an interesting case of stroke thrombolysis named Out of Window but Not Out of Mind. I now take pleasure in welcoming our second speaker for the day. Our second speaker is Dr. Kailash Mishre. Dr. Kailash is a consultant neurologist at Basawa Neurocare Center, New Delhi. He has presented papers across national and state level conferences, and he holds special interest in electrophysiology and EEG. He'll be presenting another interesting case named A Deceptive Case of Recurrent Focal Neurological Deficit. With this brief introduction, I once again welcome and thank all our faculty members who are present here today. And I would now request our course director, Dr. U.K. Mishra sir, to kindly give us the opening remarks.
Thank you very much. Am I audible? Yes, sir.
Yeah.
Yes.
Thank you. Thank you very much for giving me this opportunity. And as we were discussing that COVID pandemic brought us a difficult problem of keeping alive, expressing yourself, examining patients, doing your work. And, the teaching program was an important the real face-to-face presentations, of course, ideal, but in its absence, we had no option but to go on to online presentations. But online teaching programs always are a problem. They don't have the same intensity of interaction. You can interrupt, you can go back, you can talk, and you can have long discussions. Whereas these online programs, have a limited life. You can't go on very, very long time. People get tired, attention span, communication is also a problem. And then when we take an online program, the problem for any learning program is the learner. And the learner, usually learning is associated with young people. And here we have adults. Everybody is beyond 20, 25 years. And educating people in that age is a big problem, because the inherent element for learning is the curiosity, which is more important in the younger age. Children are curious, but as we become aged, many adults also have curiosity of a child. I'm not saying that, but generally adults learn because of certain advantages. Now, that advantages, of course, may be finding something new, finding something innovative, but or how you can treat your patient better, how can do your research, how can you diagnose better, and things like that. So these are the problems which have to be integrated in a program, in an online program. And the case discussions were the best because they are short, they directly interact, you identify with them directly, and you learn what to do and what not to do. And that is the reason, I don't know what was the assessment of the organizers, that how many sessions they will have. But even after doing 8 or 9 sessions, you still think that there is no aging in the program. The program still looks vibrant. Every program, at least I learned something new, and what to do and what not to do and how to do it better. So I think this is a very, very lively program, which I think it's a pleasure to meet my friends, very learned people who have contributed to this area and who have lived in this problem. So you always learn with them. And every time you have new presenters, who come with new information, new knowledge to add it up to our own pool of knowledge, whatever we have. So I think it's a wonderful idea. And, today the new idea came in that why not we select out the good presentations, the presentations which are, changing your thinking, changing your practice, going to trigger you or stimulate you, find out those cases and collect them together in one place and put it up for reference to others who have not been able to attend this program. So I think it's a wonderful idea to meet in, one of the, once it was asked that which is the greatest pleasure in the world. And, people wondered, what is the greatest pleasure? Is it money? It is the name, the fame? But, actually, it's a Bhartahari Shlok, which says, a good company is the best thing. Good company means intelligent people, nice people having good idea and having similar thinking. So I think what we have is one of the best things, that we are in contact with or in communication, very knowledgeable people, good people who want to treat their patients well, and everybody has a synergy and thinking in the same direction. So I think it's a great thing. I don't want to repeat the shlok, it will become boring, but it's a Bhartahari shlok saying that a good company does everything. Good company is the ultimate. Thank you very much.
Thank you very much, sir, for your very kind words. I would now request Dr. Ashokan, sir. Let's start the program, sir. Can we, what about your opening remarks, sir?
Yes, I think we'll go ahead. We'll start the program.
Okay.
Yes.
Okay. I would request Dr. Bohra to kindly present his case.
Good evening, everyone. Am I audible?
Yes, sir, but your video is off, sir. If you can start your video.
Sure. I believe the video is also on.
Yes, sir. Yes, sir.
Yeah. Good evening, everyone, and thank you for giving me this opportunity to present in this forum. So, although this thing is all about thrombolysis, but my case is obviously as per the heading, it is out of window, so thrombolysis was not there. But still, there is something which we did for a patient who was out of window for IV thrombolysis as well as thrombectomy based on the guidelines. So coming up with the case, patient was a 60-year-old female. She used to live alone and probably had a wake-up stroke. She was found with right-sided weakness, inability to speak or understand around 7 a.m. in the morning. They went to some hospital where patient was evaluated, and patient reached to us around 8 hours after being found to have stroke. So obviously almost all windows were over. No window for IV thrombolysis and probably no window for thrombectomy. On examination, patient was conscious, but she was globally aphasic. She had a right human 7th nerve palsy and right hemiplegia, but there was no gaze preference. Still, our NIHSS was around 19. A CT was done at the center where she first presented, and we repeated the CT at around 8 hours. This is the CT which was done at our center. It showed a basal ganglia hypodensity, which was the acute infarct, but the cortex seems to be quite well preserved. The aspect score was around 7 or 8 in this patient, which portends a probable salvageable area. She had already undergone a CT angio before she reached to us. It showed more than 90% stenosis of the left internal carotid origin. Supraclinoid ICA, there was complete occlusion, probably no filling into the left MCA as well as ACA. So there was a large vessel occlusion. So what do we do from here? We had a few options. First option was perfusion scan. We do it, demonstrate the penumbra, but we don't have that facility with us. Second option was to do an MRI and demonstrate flare diffusion mismatch. But the patient was not that much stable that we could go ahead with our MRI. If we wanted to do an MRI, we would have needed more time as well as sedation. The last thing was whether there was a clinical and CT mismatch. So clinically, patient had a large stroke. Her NIHSS was around 19, but the CT did not show any big infarct. So that was the reason we thought that probably this patient will be helped by going ahead with thrombectomy. We explained to the family that there is a possibility that weakness may not improve because of the basal ganglia hypodensity, but her speech part should improve. And if not done, there are chances that she is being helped by her collaterals, which may fail off and the infarct may extend in due course of time. The family agreed, so we took the patient for intervention. This is the right common carotid artery shoot, shows the origin has ulcerated plaque, but no significant stenosis. From the right side, there was flow into the left anterior cerebral artery, but no flow into the MCA or the ICA top. After that, I show you the run from the right common carotid. Here we can see there are good collaterals on the left side of brain from the pial vessels of the anterior cerebral artery. So that is the reason patient's infarct has not yet built up to that extent, which we see with the middle cerebral artery occlusion. So then we went to the left common carotid artery. We took a shoot. We found an ulcerated plaque at the common carotid origin, internal carotid origin and the carotid bulb with more than 90% stenosis. In the run, we can see that there is significantly slow flow into the internal carotid artery. All the flow from the external carotid washes off, but still the internal carotid has just started and barely reaches up. So then what do? We first did a balloon dilation of the carotid stenosis. After balloon dilation, we took a catheter across the carotid origin and we found that there was complete occlusion in the supraclinoid internal carotid artery. This filling defect is the proximal extent of the clot thrombus. So we used this 3 dots, which you can see. These are the markers of solitaire stent, which is the stent retriever, and this large catheter is the aspiration catheter. So we used a technique called Solumbra, where we deploy a stent and simultaneously use an aspiration catheter. After the first pass, we opened the proximal segment. The ophthalmic artery opened up, but still there was no flow into the brain. We did 2 more such passes. With those passes, the internal carotid artery opened up completely. Middle cerebral artery was filling well. On our way out, we had to stent the internal carotid origin also, because there was still persistent fuzzy borders of the plaque. Probably patient would have had a dissection, which happens when we do the balloonplasty of the stenosed segment. With that, recovery started almost immediately. Patient started comprehending immediately post-procedure. By the next morning, patient started speaking with some amount of dysarthria. Till day 3, her weakness was persisting, but the patient was independent in her bowel bladder needs. She was accepting orally and speech was much better. So this was our follow-up CT done at about 24 hours of the procedure. We can see some amount of hypodensity in the left basal ganglia area with probably some minimal hemorrhagic transformation, but the cortex is very well preserved. And there is no extension of the hypodensity which was seen in the pre-procedure CT scan. So this is how we went ahead even without doing the high-end imaging. So the take-home message from this, I believe, is even if the availability of high-end imaging is not there, still there are quite a few patients who can be helped. And clinical CT mismatch is something which we can look for and find out those patients. Thanks a lot. If there are any questions, I'll be more than happy to answer.
Thank you. Thank you, Dr. Bora, for this interesting case. And I must say that the decision was a very bold one and also a correct one, because you had to salvage that amount of cortex, which was still viable because of the good collaterals. And this is typical of some cases of T occlusions or L occlusions when they progress a little over time, and infarct also progresses. So they come with a smaller deficit and they add up with passing hours. So those cases, the assessment is very important. As you did, and you also told that you use that CT clinical mismatch, which is definitely a surrogate of our perfusion study, some kind of information we get. But yes, I think that was the only way to salvage that part of the brain. It was a difficult one. You went across that stenosed internal carotid, went ahead, and luckily 2 passes it came out, and then you stented. So I must congratulate you for this very good work.
Thank you.
This is very, very well done.
Thank you.
Thank you, Dr. Bora, for your excellent case.
Thank you, sir.
I think that's what CT angio, if it is very well done, yes, definitely we can make out in percolation of the in contrast diffusely through the thrombus. And if it is there, if it is rather either grade 1 or 2, definitely going to help this thrombolysis and thrombectomy. But in your case, I believe there is no percolation of the contrast. Through the
on the base.
Totally blocked, completely blocked.
Yes, sir.
But still, I could make out some distal collaterals in the cortical or the cortical area. Even though the base is infarcted, basal ganglia, the cortical area, some collaterals still persistent. So it means it is salvageable. Still salvageable. So the step what we are taking is a very good step, because definitely out of window grade for thrombolysis, you cannot imagine. And you have to go for another stringent step, that is thrombectomy. And your CT, angio itself is very good. As I said, there's a clinical CT mismatch. And the CT, I could still see some distal collaterals, over the cortex. That means it's still salvageable. We took a bold step and did this. Of course, as I said, initially angioplasty, balloon angioplasty. And a stent retriever and a thrombotic suction.
Yes.
Aspiration thrombectomy. That's what you have done. And you could see the vessels opening up nicely. And with that, you could establish the revascularization and as well as the reperfusion.
Yes.
So growing slowly. Yeah, without this, probably you would have ended up with a massive, large infarct, like malignant infarct.
Yes.
And you would have ended up with craniectomy, things like that. So what we have taken, initial angioplasty, then thrombectomy, aspiration, thrombus aspiration, stent retriever, and re-establishing perfusion is a good thing. Yes, good. Thank you.
Thank you, sir.
Is there any question in the chat box anywhere?
No, sir. No, sir. May I request Dr. Sudhir sir to kindly also give his...
I think Dr. Vora, he hesitated for such a bold step because without much imaging evidence, he has taken the right step and patient also had the best outcomes. What was the risk factor in this patient which led to, was it diabetic, hypertensive or anything else?
Sir, she was not diagnosed with anything previously, but during evaluation, we found that she was diabetic.
Okay, so
but before that, she was not evaluated and not on any medication.
Right. I think very good case. And I think in many of our setups, this scenario may present. So, in resource constraint setting also, interventions are possible. And that's what this case gives that message.
Yes.
So very good example. Yes.
Thank you, sir. I think the family should be commended. They agreed knowing all the outcomes. The major issue is family not agreeing for the things.
Yes.
Yeah, but in this case, this is the only option left out. No other option.
Yes, sir.
Either
yes, sir, yes.
Either.
I explained them the adverse outcomes also. So quite a lot of time, patient families deny the procedure, thinking that they will have to face the complication. But they don't understand that even if we don't do, there are quite high chances that patient may go bad and he'll not have a good outcome. So in this scenario, they agreed, even if we told them that it is out of window and there is no other option available.
So I think my last comment is, and in this kind of scenario, out of window but not out of mind, but when it comes from out of pocket expense, there are a lot of problems come.
Yes.
I mean, convincing the family and the possible bad outcome and the long stay and maybe a hemicraniectomy, all these, very difficult to convince.
Definitely.
It is another really
definitely. So what we do is we try to reuse things. In this patient, we used almost about 7-8 hardwares, but only 2 things were new, of which one was the stent, which we cannot obviously reuse. But that probably saved them quite a lot of money.
Provided they understand that.
Yeah.
Appreciate that.
Definitely.
That is important. It's because of the good outcome they appreciated it.
Yes, sir. Yes, sir. Definitely. So, it is a very big hindrance in even giving options to the patient sometimes. Yeah, if we see that we feel that family is not that much understandable, then we try to do negative counseling also sometimes.
Yeah, that's the reality, unfortunately.
Yeah. Definitely, these people might end up with a hyperperfusion and hemorrhage.
Definitely, sir.
Blame us. No, you have produced the hemorrhage.
Yeah. This patient, we had to load with antiplatelets on the table, and then we had to give our GP2B3 inhibitors also. So I wanted to keep the patient intubated for about 2-3 hours, but to my surprise, I found that anesthetist had already extubated the patient. So I said, okay, let it be. Keep our fingers crossed and try to control the blood pressure as much as possible. So
it was a heroic task.
Yeah.
Commendable. I must
thank you, sir. Thank you.
Mishra, sir. Sir, you're on mute, sir. Sir, you're muted, sir.
Thank you very much for a very, very interesting case. And no doubt, the mismatch between clinical and CT picture was the key. But when you have it brings out two things. Number one, our patients are not properly evaluated. They don't know whether they have diabetes, hypertension, lipidemia, and all these things are diagnosed while undergoing the procedure. It's a very common thing. It happens with us also, and that is our destiny. This is what we have to deal with. And then when we do counseling, again the problem is you are also not sure that whether there will be reperfusion, whether the problem will come up or not. I mean, there is a lot of and if all ends well, it's all great and it's very nice. But many times you do all your best intentions, and even then, the things don't go so well. And here you did not do any advanced imaging; you just took CT scan and went ahead with the angio and the further intervention. So I compliment you. This is a very interesting case. It'll remind us that we have, and it's very important. How do we counsel? What do you counsel? And you can only counsel when you are sure and you're willing to take the risk. Patient doesn't know anything. He will ultimately put it on you. You decide what you can. And and very good idea that you could bring down the cost while managing this patient. Otherwise, if you bill everything, the cost can be very, very difficult and patient. Thank you very much. Very interesting case. I appreciate it.
Thanks a lot. Thanks.
With your permission, sir, should we move on to the next case? Yeah. Okay, so I would now request Dr. Kailash, sir, to please present his case.
Can you share my PPT?
You want me to share?
Yeah.
Give me a minute, Dr. Kailash.
Right. Sure.
Dr. Neha, we are sharing the PPT. I think you are on mute.
Sir, I'm trying to share. It's not getting loaded.
Okay.
Maninder, can you try sharing it, because you also have it with you? It's a heavy file, sir. It's not just opening.
Okay.
Trying from my side, Maninder, hello?
Maninder, are you there?
Yeah. Let me try, because I'm logged in from the mobile phone. So I don't think I'll be able to, share this.
Okay. Or you can just mail me. I can try and phone.
Yeah, I'll do that.
Sir, I'm doing that.
Dr. Kailash, meanwhile, can you try at your end if it is possible? I think you shared just now. I could see.
Has it come?
No, sir. I think, sir, you can open the PPT and then share. You can just open this PPT and then you can see the share arrow at the bottom, which is a green color. And you can just click that and select the PPT. Yeah, now you can open the PPT. I can see you have shared the screen. You can just open the PPT or you can go to the PPT window.
Yes.
Give a second, I received. I will just open that. Just a minute, I'm sharing. Is that okay? Dr. Kailash, can you see my slides?
Yeah. Okay. Okay. Shall I go ahead?
Yeah, please.
Yeah. Good evening, everyone. I am Dr. Kailash Mirche. I am a consultant neurologist at Continental Hospitals, Hyderabad. So I will be discussing with you a case which was partly treated in the first half in Bangalore by some other neurologist. As the patient was a native of Hyderabad, so in the second half he came to me. So some of the investigations I could drag from the previous reports, and some we got it done at our center. So as it's a no thrombosis national workshop, I thought I will share a case which was interesting case on thrombosis. So, okay, next slide. So actually this was, we have seen it long back, almost 4 years back, pre-COVID. We saw a patient who was a 61-year-old non-smoker, non-hypertensive, non-diabetic patient who presented with slurred speech and deviation of angle of mouth to the right, which lasted for only 15 minutes. So patient came to hospital, they did MRI, which showed area of diffusion restriction at 2 sites. So was evaluated for stroke, as the patient had infarcts in both the hemisphere and different vascular territory. So was thought of probably embolic stroke, and angio was done to rule out any vascular occlusions. So MR angio was done, which was nearly normal without any much bleeding or anything. So, so this is even the distal vessels were branches were normal without any occlusions. CT angio was done, even posterior circulation, blood vessels were absolutely normal. So next. So in view of suspected cardioembolic stroke, transthoracic echo was done, which was negative for any LV clot, and later transesophageal echo was also done. We thought they could have missed 2 mm, less than 2 mm clots. So even transesophageal echo was also normal. He did not have any clots in the LV. To rule out the AF, we did 24-hour Holter monitoring, which was unremarkable. Later, we did it for a week. Long-term Holter monitoring was also done, which came out to be negative. We could not find any paroxysmal AF episodes in those 7 days. We went ahead with carotid Doppler, which was normal. Patient was treated as embolic stroke with single antiplatelet. Actually, in Bangalore, it was started on a single antiplatelet. After 15 days of first episode of stroke, which lasted only for 10-15 minutes, he was absolutely fine after that on single antiplatelet. He developed one more episode of difficulty in walking, deviation of angle of mouth to right with aphasia, which also lasted for only 10 minutes. So MRI was done, which showed a well-shaped flare and flare hyperintensities involving the subcortical and lobar white matter of left post and central region. And there was a new area of diffusion restriction in the post-central region. There was no contrast enhancement of meninges or any beading or enhancement of the vessel wall. So patient was started on, was changed from single antiplatelet to dual antiplatelets. Next slide. And anyway, patient did not had any deficits. So he left the hospital. Just after 10 days of this episode, he developed another episode of right lower limb weakness, and MRI showed a new area of diffusion restriction and flare hyperintensity in the left precentral gyrus. On dual antiplatelet, patient was getting recurrent, fresh area, different vascular territory diffusion restrictions with neurological deficits, with normal angiography and without any vascular risk factor. So probably they thought was of demyelination. So patient was evaluated for that. All routine blood investigations were done. Hemoglobin was mildly, he was anemic, platelet was near normal, WBCs were normal. One highlighting thing was his ESR was 110 mm of Hg. Creatinine was normal, viral markers were negative, urine routine was normal, liver function tests were not within normal limits. Total protein was 7.1, albumin was 3.3 and globulin was 3.8. Calcium and uric acid were within normal limit, and fasting lipid profile was also within normal limits. So in view of recurrent stroke, even though angio and all was normal, they did a CSF analysis which showed a protein of 117 with 54 of sugars, with simultaneous blood sugar of 140. CSF was showing 16 cells with 100% lymphocytes. So CSF was sent for gram stain, ZN stain, KOH, culture, biofire. Everything turned out to be negative. Even it was sent for malignant cells and was negative for malignant cells. So actually we went, at this time patient came to us. So we did a DSA. Can you just show that video, DSA video? I have already shared with you.
I think it's not embedded, sir, because it has to be embedded. I can see only, I could not see any video here.
I have shared the videos.
Separately, then shall I share?
Yeah, you can share. I can stop.
The video is just getting loaded, sir.
Shall we continue, sir, with the presentation?
Yeah, okay, that's okay. We'll continue the
because this is just going on.
Yeah. Hope my slides are visible.
Yeah. So 4-resal angio DSA was done just to rule out any distal bleeding or anything, because CSF was cellular and proteins were on the higher side. So DSA turned out to be normal. There was blood vessels were absolutely normal. So meanwhile, patient already, he also told us the history that a month before the first episode of stroke, he had a low backache and had a lower limb weakness with acute urinary retention a month back. For this low backache, he visited a neurosurgeon where they did a lumbar spine MRI which showed mild disc prolapse and was managed with epidural steroid. So when they came to a neurophysician with this history, they were thinking of some demyelinating disorder in the spine and in the brain. So they, and even CSF protein was on the higher side. They sent CSF, NMO antibodies and MOG antibodies. This was at that time, it was sent to Nimans from Manipal Hospital. Anyway, both were negative. Then next. Then vasculitis workup was done for the same patient. This was, from this we took over the patient. We saw the patient. The ANA profile was done. where double-stranded DNA was borderline positive. We repeated this test and it came out to be negative. Borderline positive came out to be negative in repeated DNA profile after 2 weeks. So next slide. So we evaluated this patient extensively for the cause of coagulation. Next slide. C ANCA was negative, P ANCA was negative, ACE levels were within normal limits, complement levels were within normal limits. Next, no, previous slide. Previous slide. We did even VEP. VEP was normal. CSF oligomer bands were negative. Next slide. So phospholipid antibodies were tested. Both IgG and IgM were within normal limits. Next slide. Serum homocysteine was within normal limit. Factor V Leiden mutation was done. Which was not detected. Prothrombin gene mutation was negative. Methyl tetrahydrohydrate reductase gene mutation was tested. That was also negative. Next slide. So we could not get any cause for recurrent strokes. So we went ahead with whole body PET scan, which showed hypermetabolic bilateral and after the second episode of stroke, in view of high CSF proteins, patient was started on methotrexate and steroids. So it was almost 4 weeks. Patient was on almost 60, 50, 40, 20 mg of oral omnacortil. So when he reached us, we already almost seen him after 4 weeks. So PET was showing hypermetabolic bilateral enlarged adrenal glands, suggestive of bilateral adrenal hyperplasia. And they mentioned bones, no abnormalities seen. And rest of the thing was negative for any malignancy. It was just a adrenal hyperplasia. Can you just share the PET video?
No, because it is not embedded. We will not be able to share. We can.
You want video too?
Yeah. This video, if you can upload.
Okay, I'll try, because when I tried to play, the system gets stuck. I'll just try.
I think, sir, we are not. Yeah, are you able to share? No.
It would come in 1 or 2. It takes 1 or 2 minutes. Maybe we can just go ahead and we'll play both the videos, Dr. Kailash. We'll play both the videos together at the end of your case, because it will take 2 minutes. It will then open up.
Yeah.
Yeah, we'll play. Yeah.
Next slide. Anyway, it was reported as a normal PET, just a mild adrenal hyperplasia. When we saw the PET images, previous slide. Yeah. When we saw the PET images, we felt that the bone marrow uptake was a bit on the higher side than the normal PET what we see. We cross-checked with the our radiologist. They told that's a marrow uptake. That's a normal marrow uptake. But we were not getting any reason for his recurrent thrombosis. So we went ahead with, and we had one more clue. Can you just go up the second or third slide?
This one?
No, second or third. The beginning.
Electrophoresis?
No, in the beginning. First, not down, up.
Yeah. I think what Kailash wants is that ESR 110 and AG reversal.
ESR was yes, sir.
Yeah,
ESR was 110, sir. And one more thing was serum proteins was 7.1, albumin was 3.3, and globulin was 3.7.
AG reversal and calcium was a little bit low. And
little bit low.
Yes,
so
8.5.
Serum immunoelectrophoresis and immunofixation. So we went ahead with bone marrow aspiration and bone marrow biopsy later. Next slide. Bone marrow aspiration was showing
lymphoma.
Yes, lymphoma. Plasmacytomas are basically almost 20% of bone marrow cells. Just wait now, don't move the slides, please, sir. No, next slide, sir. Next slide. So plasma cells account for 15% of marrow cellularity, and there were occasional binucleated forms and plasma cytoblasts were noted in the peripheral smear. So they advised for bone marrow biopsy. So binucleated forms in the bone marrow and plasma cytoblasts itself indicate it's a plasma cell dyscrasias, and anything more than 5 to 10% of plasma cells in the bone marrow is usually plasma cell dyscrasias. So we did a refined biopsy. Next slide. So we tested for antibodies. So half of just one second. Immunocytology was done, sir. CD1, I think half of the slide is not coming. CD138, lambda, and kappa were positive. CD138 is a marker for plasma cells. There was a increased cellularity of plasma cells. These are all black dots. This is all CD138, which was 10, and positive for even lambda and kappa. Majority of the plasma cells were positive. Next slide. So 138 was positive in plasma cells with increased cellularity in the plasma. 75% of the trephine biopsy shows normal trabeculae with marrow showing 75% of cellularity. Plasma cells were predominant with the presence of blasts. Blasts is very significant with binucleated cells. So actually it was a plasma cell dyscrasias which presented with recurrent thrombosis, and later patient was handed over to medical oncologist. So he was started on other immunomodulators and CHOP therapy or something was started, but after we transferred the patient to the medical oncologist, within 22 or 23 days, patient was succumbed to the disease. Anyway, he did not develop any new focal neurological deficits, but over the period of time, he developed a deep sinus thrombosis. In the leg, he developed venous thrombosis, and then ultimately his hemoglobin came to 675. His WBC came to 1,800, and ultimately he succumbed because of sepsis, because of infections. Actually, this case is not for intervention or anything, but as it was no thrombosis, so I thought we'll present this case.
Well, Dr. Miche, I think this is a very interesting case, and a lot of things happened over the time, and a lot of, unexpected findings came up with investigations. And before I go into the discussion, do you have the follow-up? There are 2-3 events, one the TIAs and the stroke. So do you have the follow-up MR images? I mean, do they all look like embolic stroke? As per
Yes, sir, all the three.
All the three.
3 MRIs were done. We actually got only 1 MRI. I could not retrieve the other 2 MRIs, but I had all the reports with me. Only first MRI, I saw the first MRI, that's it.
So in that case, and this case fulfills the criteria of ESUS. because they are an embolic stroke of uncertain sorts, and you have investigated thoroughly on the angiogram and other cardiac workup, and everything has been done. So now the question is, when it turned out to be a plasma cell dyscrasia, how do we correlate between this embolic stroke and plasma cell dyscrasia?
So it was not an embolic stroke, sir. It was a hypercoagulable state which is causing recurrent thrombosis.
Okay.
Of different areas.
Okay, but these were, there are a few unusual things. I mean, though these are three different events, but surprisingly, they all happened in the arterial side. In case of hypercoagulable stage, sometimes we see both arterial and venous thrombosis. But in this case, we only see arterial.
All the events were arterial, but later he developed venous thrombosis, but in the leg.
Okay.
That was almost 1.5 months after the strokes.
Okay. Yes. So I think that is one mechanism of. And second thing is that this is probably the reason where these ESUS patients have been tried with NOACs, but those trials were negative for many reasons. I'm not going to the detail of that. So that's why we are wondering whether ESUS should really be treated with only NOAC, or because we do not know which one is better. In this particular case, he might have responded to oral anticoagulations had we know the mechanism from the beginning. Second is a combination, probably aspirin and low-dose rivaroxaban could be one way of treating this kind of cases, ESUS, where you do not know the exact mechanism. But this is really a very unusual case, the way it presented and then unfolded. So, Dr. Asukan, sir?
Yeah, thank you, Dr. Kailash, for this very interesting case, very well worked up and extensively worked up. So, first of all, as you said, I feel that it's a venous infarct. What I had seen initially, probably venous infarct. But of course, you have done DSA and all those things, and the venous is normal. There was no venous occlusion, isn't it, anywhere? Dr. Kailash? I mean, cerebral
no venous occlusion, sir. Yes. MR, angio, arterial, venous sinus thrombosis, we saw all of that, sir. Venous sinuses were fine.
Anyhow, here the catch is ESR, very high ESR, 110. That you have to explain somewhere, isn't it?
Yes,
so,
albumin, globulin,
raised ESR and increased fibrinogen, serum fibrinogen. These two things say from the beginning it's
globulin was more than albumin, sir.
Yeah, that's what I'm telling. ESR, globulin, IgG. So these things, and plus, of course, serum fibrinogen levels, all these point out to hypercoagulable state. And to my mind, which has caused small venous infarcts, which looked like arterial, what it may be. And subsequently, and further workup, of course, deciding factor here is bone marrow. Only with the bone marrow you could confirm things. Yeah, that's what. So, of course, it's treated with the steroids, etc. and methotrexate. Am I correct? Methotrexate. Yeah, I think it's a demyelination, and demyelination, of course, looks more like venous throat, and finally ended up with the DVT of the leg, which showed up lastly. So this is basically a hypercoagulable state, which has caused venous infarcts, and you could diagnose with the bone marrow as plasma cell, isn't it? Plasma cell. So as Dr. Jayantarai told, probably combination of anticoagulants, oral anticoagulants, along with other things would have helped. That's what I feel, either VARF or NOVAC. Yeah, that's what. But very interesting, very extensively worked up. But repeatedly, all these things negative, your ANA, dsDNA, and your CANCA, PANCA, that profile, everything is negative. So unlikely to be demyelination. So ultimately, it's plasma cell and a hypercoagulable state. Yeah, venous thrombosis everywhere. Thank you.
Dr. Sudhir, would you like to make some comment?
I think it was an interesting case. It took a long time to diagnose, but I think many times we just ignore the ESR and AG reversal. So I think the learning point is that, especially if ESR is more than 100, and if the lab is good, we have to give importance and try to find the cause. And here the patient also had anemia and also AG reversal, calcium 8.5, and uric acid 6.6. There are multiple things, and patient gave a history of back pain. Of course, it was labeled with as the disc prolapse. But because we're all neurologists, we are thinking of something in the brain, and then we ignore many of the blood test findings. But this is one case that highlights that if we had chased those, possibly would have been diagnosed earlier. But I think it's a good learning from Dr. Kailash's case. He has presented a very good case, and also CSF was abnormal. So then the doubt about demyelination came up. But the MRI picture was not suggestive of demyelination, definitely. And I think what Dr. Kailash, in your CV, it was mentioned as Basava Hospital in Delhi. So do you work in 2 hospitals now?
I don't know how they made me in Delhi.
Yeah, because
I'm Hyderabad.
Yeah. Okay. So I think you are still in Hyderabad only, not Delhi and Hyderabad 2 places. Okay.
No.
Yeah. Okay, very good case. I think deserves to be commended for extensive workup, and finally you nailed the diagnosis. Unfortunately, patient succumbed, but that can happen.
Mr. Mishra, sir?
A very interesting case. I was thinking that if this case comes to me, what would I have done? The most important thing was that he had backache, and that was diagnosed to be disc, and steroids were injected, and the patient probably improved or not improved. I mean, that's different thing. And then, of course, raised ESR, and there were multiple territories of, hyperintensities, which appeared to be embolic infarct, and the differential diagnosis is to either embolic or venous infarct. So at that time, I would have done, more extensive evaluation of if a cardioembolic source was ruled out, then a D-dimer would have been helpful. And D-dimer, if it is raised, it would have been given some inclination for this, and then maybe an ultrasound abdomen could have been, whether we get some, thrombosis of veins or portal system, etc., could have been an thing in retrospect. Then, in this case, what was the urea creatinine like? These patients are dehydrated, and quite often they are in hypercoagulable state, and there may be urea creatinine may be elevated. If it was there or probably normal.
It was normal, sir. Renal profile was normal.
All right. And then PET, of course, was normal. Did not reveal, but maybe plain X-ray film. Sometime when we do skeletal survey, we detect abnormalities, So, but with modern neurologists, we don't do X-rays. But maybe in retrospect, a lateral X-ray film could have shown something which probably was missed on MRI. I'm thinking, what could have been done. And then later on, you say that the patient developed infection and venous thrombosis. So that again, and, it was a plasmacytoma. So in the end, if I get this patient again, I will give great importance to patchy bilateral lesions, which I will also consider a venous infarct, maybe look at the venous images more carefully. A D-dimer would have been helpful. And then probably look at a film of the spine, do a skeletal survey if it is possible. And of course, bone marrow, hit the diagnosis. So maybe a bone marrow examination I would do earlier than later. And later on, patient develops sepsis. These patients are very prone to infections, and they develop sepsis and meningitis later on. So I think a very, very illuminating case, very learning case. Thanks that you presented this case, even though it did not require intervention. Thank you very much. I learned a great deal from this case. Thank you.
Thank you, sir. So we come to an end to the program, sir.
I think, sir, Neha, there is a very interesting question by Dr. Vikram Bora.
Yes. Sorry,
I will just read out. Maybe our faculty can comment. It is unrelated question, but in heterozygous methyl tetrahydrofolate reductase mutation in young ischemic stroke patient, does it warrant anticoagulation? And second question is, familial ischemic stroke in 2 generations found to have a proteins and CS deficiency in 2 brothers. Should they also be kept on anticoagulant?
Well, Sudhir, you want to take that?
I think you are the right person. You can.
No, I mean, well, that's fine. So, heterozygous mutations, usually they do not warrant anticoagulations if they had ischemic stroke. If you look at the AHA guideline, they have limited the use of long-term anticoagulation in case of antiphospholipid syndrome, basically. Rest of all these thrombophilic conditions, there is no strong recommendations from the AHA guideline because of there is no evidence is also low. So if we consider heterozygous, then and they present with only arterial ischemic stroke, then we do not have recommendations for long-term oral anticoagulations. In case of homozygosity, and especially patients who are presenting with arterial and venous site thrombosis, they probably warrant more of oral anticoagulations, not only a single arterial stroke in heterozygosity. Yeah, correct me if I'm wrong. That is my understanding. And regarding the second part, again, protein C proteinase deficiencies, I mean, I don't think there is any prophylactic role of oral anticoagulations in these kind of situations until unless they develop any event either in the venous side or the arterial side. Because this activated protein C proteinase deficiency is a different thing, and it's not always reflect into a clinical situation. So prophylactic is not indicated.
Sir, this protein C proteinase deficiency, both the brothers have had stroke, arterial strokes.
Okay, arterial stroke.
Yeah.
Okay, and was it a recurrent or the single event?
No, both of them have had only one event till date. They are around 50 years of age, both of them. Their fathers also had stroke. Fathers.
Also, protein C is deficient.
Both the brothers are protein C and S deficient. Their father is no more, so we cannot evaluate them.
Okay. So, yeah, I don't know. I mean, if it is a single event and looking at the level, we probably have to decide. But in homozygosity only, it is recommended. But otherwise, the heterozygous conditions.
Major issue was the patient wanted to know that because 2 of their generations have had stroke, they are disabled. They wanted to know if we can do something for their children, whether we can start them on some treatment, find out whether they are at risk. So the reason was that whether we should do the test for the kids also, and if found, whether we should keep them also on anticoagulation.
Since we do not have any guideline or recommendations on that issue, that we, screen them for deficiencies and treat them prophylactically, then, other than knowing it, there is no further benefit out of it. So I probably would not recommend that.
Yeah, I have also not done those tests yet.
May I say something? May I make a comment?
Sure.
You see, that's right. What was already said is correct. But many times we see these problems are more commonly with venous stroke, but sometimes with arterial stroke also. And I recall a patient who had hyperhomocystinemia, and then we look at B12, folic acid, and other things, and sometimes you find a reason there. So if the patient does not have evidence of EPLA and other gross immunological disorders, then we should check at easily treatable conditions. And if we can treat with, we can find a cause. If there's hyperhomocysteemia, B12 deficiency, folate deficiency, then this can be easily corrected. And because giving lifelong anticoagulation is a serious matter, and the maintaining it at an adequate level and the complications therefore, and etc. So it's a very limited role of long-term, lifelong anticoagulation, which was said that it is not recommended in most of the cases, but we must find out a reversible cause or a treatable cause and treat it.
Absolutely. And VK is the only option in this kind of cases. So maintaining INR lifelong is a
very difficult. What we have done, actually, we have done a study on how you anticoagulate the oral anticoagulants, and only 40% patients are adequately controlled. Either they go hypercoagulation or hypocoagulation, and therefore you are again struggling to maintain, and the toxicity of both is prohibitive. So therefore we have to be very careful and very choosy where to give oral anticoagulants.
Right, sir. Sudhir, any comments? Asakan, sir?
Yes, I totally agree, because you cannot go for lifelong anticoagulation for such of these patients. Probably if the thing is provoked, and if you get a stroke or something like that, probably you have to get into the matter seriously. But a prophylactic long-term oral anticoagulants, no guidelines exist. Yes.
Absolutely.
Definitely agree with that. Yes.
Thank you. Any more questions, Neha?
There's no questions for this.
No, sir. Questions are answered. So shall we then call it a day?
Sure. Thank you. Yeah.
Okay.
Wonderful. Great evening. Yeah.
Yes, absolutely. Great evening, sir. Thank you so much for taking out your precious time on a Sunday evening for this program. And we stop here. We'll come back next month again with 2 exciting cases of no thrombosis. And we look forward to again another enriching session next month. Till then, all of you stay healthy and stay safe. Good night, everyone. Good night. Thank you so much, sir, for joining us.